So thank you for the introduction. Just a little bit about me. I'm a fourth year student, like she said, and I like seeing like a lot of pathologies. When we come across certain rare pathologies, I like to document them, do a case report on them, just because a lot of times these pathologies can have terrible prognosis if you're not able to pick up on it. So it's good to just talk about it a little bit and like some red flags, certain things. So this was one of them that I came across last year, and it's CD163 spindle cell histiocytoma of the right breast. So just a little bit of background information because I was not very versed to this when I came across this originally. So histiocytic sarcoma, it's a rare malignant neoplasm originating from mature histiocytes, typically characterized by the expression of CD68, CD163, like in our case it's CD163, and or lysozymes. So there's a paucity of published cases regarding histiocytic sarcoma, particularly those of primary origin. And we'll see in a little bit that mine was a or the patient that I saw was primary origin. And as far as risk factors goes, there's no environmental or hereditary genetic factors that have been identified as contributing to the development of HS. And when I say HS, I'm just referring to histiocytic sarcoma. So although this case involves primary neoplasm, about 25% of HS cases develop secondary to the hematologic neoplasms, such as follicular lymphoma, myelodysplasia, or acute lymphoblastic leukemia. And a major barrier with this and just these pathologies, especially these rare pathologies, is a barrier to early identification of this aggressive neoplasm. It has a lot of varying presentations clinically, so it can present with symptoms of metastasis or as the primary origin, but we'll get into that when we see our case a little. And they're often nonspecific symptoms. So HS can manifest as a solitary mass or, if severe, multi-organ disease with extranodal involvement. So in this report, we're going to present a case of a 56-year-old Caucasian female with CD163 positive histiocytic spindle cell carcinoma of the right breast. So before we get into that, just a little bit about our patient. She's not super well versed with medicine. Like, she didn't have a primary care as for a very long time, so she's a little bit out of touch. And the reason I say this is because clinically we don't really pay attention to these things when we're learning in medical school, especially preclinical years. You kind of learn the gold standard of treatments, but this case, along with the rare pathology itself, it taught me that a lot of times compliance and regular visits, these are really limiting factors in how well we can treat our patients, even after we've correctly diagnosed the condition. So anyways, for our 59-year-old female patient, she had a past medical history of COPD, hypertension, and generalized anxiety disorder. And that anxiety is a little bit important. It's going to come back later, but just keep that in mind that she does have a rather general anxiety disorder diagnosis, and she's a little anxious. And she presented with a painful lump in the right breast, I'm sorry. And that was her chief complaint with, pretty much that's the only thing she came to us with. So we kind of had to work from there. And we did our initial imaging and all that stuff. So what we went with first, because of her age, we went with the mammography. And keep in mind these dates I'm going to mention as well. This was in November of 2023. So this is important because we're going to start to highlight the rapid nature of this disease. And so in November of 2023, we did a mammography and an ultrasound, which revealed a large lobulated hypoechoic mass with internal calcifications, prompting recommendation for biopsy. So patient canceled her and rescheduled her biopsy 3 times due to anxiety about the procedure, reported denial of potential severity of her disease. Now, this is it's very important as healthcare professionals for us to understand that this is not her fault. She's anxious. She doesn't know what's going on with her. And she has a history of anxiety disorder. So there's a lot of personal anxiousness that comes along with getting further testing and all that stuff. But when we did do the biopsy, as you can see on these slides over here, which we thought was really interesting, that eventually confirmed the diagnosis of CD163 spindle cell histiocytoma. And a little fun fact about how rare this pathology really is, when we initially had sent this to pathology, they returned the slide and said this isn't breast tissue. So it took us resending it back for them to be like, I'm sorry, I've never seen this before, but we can confirm this is a very rare cancer. And then we did a subsequent CT of the thorax, which revealed multiple pulmonary nodules suggestive of metastasis. So despite the initial attempt to manage her condition through biopsy and referral, the patient's anxiety and discomfort delayed the diagnosis, delayed the treatment, and just rapidly progressed to a critical state. Again, it's clearly not her fault. It's in this situation, this kind of highlights the importance of having psych on board, or making sure that you're mentally checking in with your patients as well. But we'll discuss that in a little bit. And then just a little bit about the clinical course of the patient. So, 2 months after her diagnosis, the patient presented to the emergency department with worsening symptoms, including severe breast pain, hypoxia, and signs of infection. So this was 2 months after. And even initially, there were signs of metastasis, so we don't know exactly when she started having this cancer or symptoms of, but you can clearly see that it is rapidly progressive, especially if it's unaddressed. So we admitted her for the respiratory failure and right breast cellulitis, because we were suspecting a pulmonary embolism secondary to the malignancy, but the patient refused the recommended treatment. She was just having a lot of anxiety with pretty much anything we were trying to do to work up her condition. And so we did what we could with our aggressive management. We included IV antibiotics, anticoagulants, pain control, and then she just expressed a desire for palliative care before developing altered mental status. And she was transitioned to hospice and died that same evening, which it's really sad, but it's very important to talk about these things as well, because the question then that I try to do at the end of all of my papers is what could have been done differently and what can we do to improve the prognosis for these conditions. So, like I said, our patient's clinical course was marked by significant pain, rapid disease progression, and resistance to conventional diagnostic procedures due to severe anxiety and discomfort. So, in my opinion, the key to addressing the high mortality rate associated with histiocytic sarcoma is to better understand its presentation. The identification may be hindered by HS's wide array of clinical manifestations. While HS can occur at any age, the median age is around 57, so pretty much around where she was, and with a median survival of 5 years. Um, I'm sorry, with a median survival of only 6 months. I'm sorry, it's 57 years plus or minus 5 years with a median survival of 6 months, making early diagnosis critical for improving our patients' outcomes. So furthermore, because HS is an ambiguous disease, proper history, imaging, and biopsy are essential. In the case of our patient, she was referred to appropriate specialties for imaging and procedures, but anxiety and a potential lack of understanding of the purpose of the procedures hindered prompt results. So, despite education from her physician and other healthcare workers on the importance of quickly identifying the cause of her breast lesion, our patient regularly refused treatment. And I do remember she even once said, I think you're all overreacting. It's not that bad. And I do just want to reiterate one more time, that's not anything that I'm saying is a bad thing on her part. I'm just trying to emphasize how important it is to mentally check up on your patients, see their level of understanding, see their level of comprehension of the pathology, and work from there. So, this patient's outcome of death highlights the importance of a multidisciplinary team in addressing the patient's concerns and fears with diagnosis and treatment regarding their illness. This multifaceted approach to patient care could further enhance patient compliance and minimize the procedural anxiety associated. This approach can also reduce secondary complications such as infections and organ failure, which is what our patient had came up with or came in with. Addressing patient anxiety to foster rapid follow-up and identification of this deadly cancer could improve survival outcomes. One patient survived 50 months after her diagnosis, likely because she did not have metastasis when her HS was discovered, and likely because she had a stronger multidisciplinary team working with her as well. So in the case of our patient, both her extensive METs and secondary cellulitis may have been avoided by implementing these approaches and strengthening patient physician interaction through more frequent follow-ups. Um, Multidisciplinary teams for breast cancer treatment in Hungary recommend including psychiatrists from the time of diagnosis to support patients as they cope and consider and begin treatment, which is very interesting because this is not how it's necessarily practiced here, but the whole point of this presentation is that maybe it should be. So while our patient was offered frequent follow-ups, her illness anxiety led to missed opportunities and canceled biopsies as an unfortunate fact, which is not uncommon among women with breast cancer. Perhaps including a psychiatrist to help her cope with the possibility of having cancer could have changed the outcome. So, in conclusion, as demonstrated by previous literature, primary HS is a rapidly progressive and fatal neoplasm with a diverse clinical presentation. So the two-part before I conclude this presentation is just to understand that one, it's very important to see signs and how this can present. For us, it was a painful right mass. That's all we had to go off of. But then secondary, we could have built on that with proper communication, proper patient interaction, and that's usually something that seldom spoken about in your preclinical years or your textbook. We have courses that offer it, which is great, but like when we're learning about pathology and treatment, we really rarely address that aspect of it, which was the main point of why I wanted to go about this presentation and hopefully spread some awareness on it. And just wanted to thank my team who really helped me with this presentation and with the pathology associated with it. And yeah, if there's any questions, you guys please feel free to ask me. I'll do my best to answer them.